All right, hi everybody. So I'm going to introduce our first speaker. Lisa Manick is a registered dietitian and certified diabetes educator at the Adult Cystic Fibrosis Program at St. Michael's Hospital in Toronto, Canada. She's been working with people with CF since 2012, both in the outpatient clinic and on the inpatient unit, and her areas of interest include CF-related diabetes and digestive health. So let's welcome Lisa Manick.
Thank you very much for the introduction, and thank you for having me here. I'm excited to see a fairly full room. I wasn't sure the very first session of the conference if people would be still sleeping or not, but as mentioned, I'll be talking today about adult lipid management for the bulk of my talk and a little bit about CF-related diabetes complications. So I have no relationships to disclose related to this presentation, other than the fact that I am not an expert in lipid management, and I did a lot of reading and research to prepare for this talk. So please keep that in mind when question time comes. So the bulk of my talk today will be focused on adult lipid management. So why are we talking about lipids in CF? Historically, people with CF have low cholesterol levels compared to the general population, and this has been documented widely in the literature, and I've just referenced a couple of more recent studies. However, we know with an aging population, dyslipidemia is expected to become more prevalent. This figure shown here really nicely highlights that dyslipidemia is a significant risk factor for cardiovascular disease, in addition to other factors such as older age, high blood pressure, and obesity. The figure also shows that there are some potential CF-specific risk factors for cardiovascular disease, and these may be things that we need to keep in mind as our population is aging. So cardiovascular disease is a topic that historically hasn't been discussed much in the CF community, since there's been very limited evidence to suggest that people with CF are at risk of cardiovascular disease. With that said, we expect that this is going to become an issue in the aging CF population because we know the incidence of cardiovascular disease in the general population peaks in about the 6th and 7th decades of life. In recent years, there's actually been some literature published on this topic looking at acute cardiovascular events in people with CF, and these are just a few papers that have been published in the last year. So for the lipid portion of my talk, I'm going to be defining lipids. I'm going to talk about the current guidelines for the general population for lipid screening, including who we should be screening and how. I'm going to go over target lipid levels, and then I'm really going to focus on dietary guidelines for general heart health, and also focusing specifically on LDL cholesterol and triglycerides. So cholesterol is a fat-like waxy substance that's involved in the synthesis of cell membranes, hormones, and vitamin D. So it is not a bad thing necessarily. Most of the cholesterol in the blood is made by the liver, about 80%, and the remaining 20% comes from diet. We often think of cholesterol, or we hear about LDL and HDL cholesterol. Those are kind of the big ones that we talk about. So LDL cholesterol is that bad cholesterol, or L for lousy. And you can see here, my pointer. Okay, well, you can just see on the slide. The LDL cholesterol is that yellow cholesterol, and it leads to plaque accumulation on artery walls, which leads to narrow blood vessels and blood clots. HDL cholesterol, on the other hand, is the blue, you can see it in blue, and it's H for healthy. It's that good cholesterol that helps absorb LDL and bring it back to the liver where it can be broken down and eliminated. Triglycerides, on the other hand, are circulating lipid particles, and they are found both in dietary fat in the bloodstream, and triglycerides are also made in the liver. And the liver specifically converts excess carbohydrates into triglycerides, and this becomes relevant when we talk about dietary strategies to help manage high triglyceride levels in the blood. In the dietary triglycerides are circulated in the form of chylomicrons, as you can see here, and the triglycerides made by the liver circulate in VLDL particles. And basically, these extra triglycerides get stored in fat tissue, and then when the body needs fuel, they get released into the bloodstream. So this just highlights sort of all of the lipid lipoproteins that we think about when we talk about total cholesterol. So you can see there's that healthy HDL cholesterol on the right. Oops, now this is working. And then those triglyceride-rich chylomicron remnants and VLDL particles on the left. So when we're talking about total cholesterol, it includes all of these components. So the current dyslipidemia guidelines that I'll be referencing throughout this talk are both the Canadian guidelines from 2021 and the American guidelines from 2018. So these guidelines are readily available and apply to the general population. There's no CF-specific guidelines for screening unless the person with CF has diabetes. So everything that I'll be mentioning refers to the general population, which I think we can probably use in our CF patients as they're growing older and healthier. So these guidelines provide recommendations for how to screen, who to screen, thresholds for treatment, and lifestyle and pharmacological interventions. I also wanted to highlight several additional documents that have been published in conjunction with or following these main guideline papers. These are all actually really great reads. I would recommend if you are interested in lipid management in your patients, and I'll be referring to some of these throughout the talk. So who should we be screening for dyslipidemia? So the Canadian and American guidelines are fairly aligned. In Canada, it's recommended to screen anyone 40 years of age or older, regardless of their health condition. However, we should be screening people at an earlier age if they have any of these conditions. Let's see if I can get this to work because I can point a bit better on this screen.
You just move the mouse over. Just slide it over to the second screen.
Sorry.
If you keep moving the mouse to the left.
Oh, there. Okay, excellent. This will be easier. So you can see here on this chart, people with diabetes should be screened regardless of age, and anyone who is obese with a BMI greater than 30. The American guidelines recommend that screening should begin between the ages of 9 to 11 and should be repeated every 5 years. And so for younger adults who are at low risk, we should be screening every 5 years for dyslipidemia. And as people get older, we should be screening every 1 to 2 years for men ages 45 and up and women ages 55 and up. And then in our older adults, older than 65, we should be screening every year. So how do we screen for dyslipidemia? Both the Canadian and US guidelines recommend screening with a standard lipid profile, and this includes a total cholesterol level, an LDL cholesterol, HDL, non-HDL cholesterol, and a triglyceride. And then there's some additional parameters that may be checked, but I won't go into those in detail today. One thing that's really important to note is that non-fasting screening is recommended, so we don't need to have our patients come fasting to do a lipid profile unless their triglyceride level is very high, above 4.5 millimoles per liter or 400 milligrams per deciliter. So for clinics that aren't doing standard lipid screening with their annual blood work, this is something that could easily be added. So we need to know how to interpret these numbers that we're checking when we do a lipid panel. And when I first started to look through both the Canadian and the US guidelines, I felt exactly as this person feels in the cartoon. It's really difficult to tease out specific targets because there's a lot of caveats. So I'm first going to highlight the commonly accepted general lipid targets. These are not taken from the Canadian or the US guidelines. These exist through Mayo Clinic, Cleveland Clinic, Johns Hopkins, and some of your labs may also be using very similar reference ranges. So you can see here the values both in millimoles per liter for the Canadian audience and milligrams per deciliter for the Americans. The one I wanted to highlight is that LDL cholesterol has two different targets listed. The lower target is the sort of bare minimum that we should be aiming for, but ideally this upper target is what is cardioprotective. So aiming for higher HDL is better for heart health. So here I'm presenting the targets outlined in the Canadian guidelines just as an overview, but I'm going to go over some of these in a little bit more detail. There are a couple things I wanted to highlight. One, I wanted to highlight that there is no target for total cholesterol, and that is the same in the US guidelines. I think because total cholesterol includes HDL cholesterol, it's not an overly valuable measure for us to be looking at and treating based on. There's also no targets for HDL cholesterol listed. The other thing I wanted to highlight is that the targets for LDL cholesterol and non-HDL cholesterol are dependent on cardiovascular risk. So there isn't just one target we need to be looking at, and that might be why your labs don't flag these values as normal or abnormal, because there's not really a set single target. So regardless of cardiovascular risk, both the Canadian and the US guidelines recommend following a healthy diet and a healthy lifestyle. As you can see highlighted here, these were taken from both of the guidelines. So I'm first going to talk a little bit about general dietary guidelines for heart health. So in 2021, the American Heart Association issued a scientific statement outlining the key principles of a heart-healthy dietary pattern. In this paper, they list 10 evidence-based recommendations to promote cardiovascular health. So I'll go through them very briefly. Adjust energy intake and expenditure to achieve and maintain a healthy body weight. Eat lots of fruits and vegetables. Choose mostly whole grains. Have healthy sources of protein, mostly from plants, and fish and seafood. If you're having dairy, low fat or fat-free. Use liquid plant oils instead of solid oils and tropical oils. Minimally processed foods should be chosen. Intake of beverages and foods with very few added sugars. Limit salt intake. Do not start drinking alcohol if you do not already. And these guidelines should be adhered to regardless of where food is prepared or consumed. So these are all really great sort of general healthy eating recommendations that apply to the general population. And I think certainly a lot of these can and should be promoted for many of our people with CF. 2 years later, a new scientific statement paper was published, and the goal of this was to align commonly practiced U.S. dietary patterns with these recently published criteria. So in this paper, they looked at a variety of common diets. You can see them here on the top. So the DASH diet, Mediterranean diet, various vegetarian diets, low fat, low carb, and paleo diets. And they basically assigned points to each of these diets based on whether they met each of those 10 criteria that I mentioned previously. So green means that it fully meets the recommendation, yellow indicates it partially does, and red means it did not meet the criteria. And from this, they found that there were 4 diets that they labeled as tier 1 diets that most closely aligned with these 10 sort of criteria for optimal cardiovascular health. So those diets are the DASH diet, the Mediterranean diet, the pescatarian diet, and vegetarian diets, whether it's lacto only, ovo only, or lacto and ovo. And you can see on the far right, some of the diets that scored quite poorly were the paleo diet, Atkins diet, and the keto diet. So I just wanted to highlight some of the key differences or what makes some of these sort of tier 1 diets unique. So all 4 of those diets, the Mediterranean, the DASH, and the pescatarian and vegetarian diets, they're all rich in vegetables, fruit, whole grains, and they encourage plant protein sources. What sort of differentiates the DASH diet from the Mediterranean diet is that the DASH diet encourages low-fat dairy, whereas the Mediterranean diet recommends that dairy should be limited. And the DASH diet is a little bit more explicit about limiting sodium. The Mediterranean diet, on the other hand, is quite unique in that it limits red meat. It says that red meat should be consumed very infrequently, and they're a little bit more explicit about use of plant oils, in particular extra virgin olive oil. So those are some statements from various US guidelines. In the main Canadian Cardiovascular Society dyslipidemia guidelines, they do make a few statements about dietary guidance for heart health, and they recommend that all individuals should adopt the Mediterranean dietary pattern. And this is because there is research, a very large study that showed that people who followed a Mediterranean diet who did not have any fat or calorie restriction had a reduced rate of death from stroke by 30%. They also recommend avoiding trans fats and reducing saturated fat intake and replacing saturated fat with polyunsaturated fats. One statement that they make that I think is really important is that adherence is one of the most important determinants for attaining the benefits of any diet. So people should choose the dietary pattern that best fits with their values and preferences, which will allow them to achieve the greatest adherence over the long term. I won't go into this in detail. I just wanted to bring this to your attention because I mentioned it a little bit earlier. This is the Supplemental Appendix S4 from the Canadian Cardiovascular Society guidelines, and it lists the expected benefits of various health behavior change, both on cardiovascular outcomes and specific lipid outcomes. So this is a great resource if you're looking at specific interventions to help improve cardiovascular health or reduce certain lipids. And all of this data is from meta-analyses and systematic reviews. And most in the audience are probably quite familiar with the Mediterranean diet, but I did just want to highlight some of the key components because it is recommended as the sort of optimal diet to follow in both the US and Canadian guidelines. So some practical tips are to switch from whatever fat you're using to extra virgin olive oil, have nuts daily, use whole grains, whether it's bread or other grains, with your meals. Have lots and different vegetables, at least 3 servings a week of legumes. Less meat, so as I mentioned, save red meat for occasional consumption or use as a condiment, so a few pieces of meat with mostly a plant protein-based meal. Have more fish, 2 to 3 servings a week, and avoid or limit things like cakes and pastries and keep those for special occasions, and have fruit for dessert more often. So we've talked about dietary recommendations for general heart health, but what about interventions to target specific lipid levels? So I'm going to talk a lot, or really focus a lot on LDL cholesterol because it is the primary target of therapy in all of the guidelines, both the Canadian and the US and the European guidelines. And this is because of the very strong link between LDL cholesterol and cardiovascular disease. When we talk about targets for LDL, it really depends on the person's risk for cardiovascular disease. In the US, they use pooled cohort equations in order to determine risk for cardiovascular disease. And in Canada, they use the Framingham risk score. So first I'll highlight the Canadian guidelines. So highlighted in yellow here, you can see that LDL targets are very dependent on risk. With if someone's at low risk for cardiovascular disease, we're aiming for an LDL less than 5 or less than 193, whereas someone who's very high risk who has cardiovascular disease, we should be aiming for a tight target of less than 1.8 or less than 70. The US guidelines are a little bit less prescriptive. They do state that any LDL level above 190 should be treated regardless of cardiovascular risk, but anything below that, they don't give specifics, and there's a lot of focus on having a clinician-patient risk discussion. So really chatting with the patient about risk-benefit and whether this is something appropriate for them. There's quite a few different recommendations from a diet perspective that can help lower LDL cholesterol. And this table here was pulled from that supplemental appendix S4 that I had referenced earlier. And you can see that some of the most significant impacts on LDL cholesterol can be through reducing saturated fat and through something called the portfolio diet. And I'm going to talk about the portfolio diet because it's not a diet that is well known to many of those working outside of lipid management. So the portfolio diet is a way of eating that can help lower LDL significantly. And it's called the portfolio diet because it includes a portfolio of plant foods that you can choose from. So there's 4 key components to the diet listed here. I'm going to go over them in the next slide, but the quantities of each are listed here. So for nuts, for instance, 45 grams is the recommended amount to have per day. And what that looks like is about a quarter or a third of a cup. So this figure here, the schematic, was taken from an infographic that has been published by the Canadian Cardiovascular Society, and you can see the link here. And it's quite easy to follow and is quite easy to use with patients. But basically, nuts, we want people to be having daily, and if they're allergic to nuts, they can choose seeds as an alternative, and they will still get the benefit. Plant protein is probably the hardest part of this diet to follow because there is a very strong emphasis on soy-based products and lentils and legumes, which for some people is really not feasible in the quantities that are being recommended. So this is definitely the most challenging part for most people. Encouraging the use of soluble fiber. And so I've listed just some tips here on the right. Just for this interest of time, I won't go through these in a lot of detail. And then plant sterols I do want to talk about because they do occur naturally in food, but but in very small amounts. And to achieve the target of 2 grams per day, I think it would be virtually impossible to get naturally from food. So the portfolio diet recommends using plant sterol fortified foods, things like margarines, yogurts. However, in Canada, these products no longer exist. I think there was just insufficient demand for them, so the companies are no longer making them. So when I was chatting with my colleague who works in the lipid clinic, she recommends to her patients using a plant sterol powder that they can add to things like smoothies or oatmeals, or you can use plant sterols in capsule form for those who are motivated to take a pill. While this diet does seem very overwhelming, the key piece of it is that it's not all or nothing. So it's not that you need to do all of these things in order to get a cardiovascular benefit. They recommend by just start by introducing one component, so maybe having nuts every day, and build from there. So I wanted to take you through a case study of a patient that I saw in clinic a couple of months ago. I've changed her name, but this is Marlene. She's a 62-year-old female with CF. She's pancreatic insufficient, has atrial flutter and hypertension and anxiety. I've listed her medications here. Her blood pressure is well controlled, and her BMI is very healthy at 23. So she did a lipid panel as part of her annual blood work in the CF clinic, and she actually reached out to me being a little bit anxious just to ask, does everything look okay? So when I first looked at her lipid panel, I thought, well, I don't really know how to interpret her LDL because it's dependent on her risk for cardiovascular disease. So there's calculators online, whether you use the Framingham risk score or the pooled cohort equations, and I plugged some of her parameters in. And it told me that she's at intermediate risk for cardiovascular disease. So her target LDL should be less than 3.5, and hers was 4.04. So an LDL above where we want it to be. The first thing I told her is, please talk to your family doctor, because obviously there may be other indications for medication, and it should be assessed by them. But we did talk a little bit about some dietary strategies. So I went through a diet history. She was taking 2 bottles of a nutritional supplement daily. She preferred to use that to take her modulator therapy because she had worries that it would interfere with food, so she was quite set on that. Her breakfast was a boiled egg, a plain bagel with butter or peanut butter. She was having chicken noodle soup and bread with butter for lunch with a little piece of chocolate cake. She had a sweet tooth, so she was having a bit more chocolate in the afternoon. Her dinner was usually grilled chicken or steak with sweet potato fries and salad with oil and vinegar. And then for dessert, she was having ice cream most days. So I pulled up that portfolio diet infographic, and we sort of went over what that looked like. And we talked about some changes that she could make, focusing very much that it's not all or nothing, and maybe even 1 or 2 changes would have a positive effect on her LDL. So some of the changes that we came up with were to replace her nutritional supplement at least once a day with a handful of nuts, which would give her sufficient fat for her modulator absorption, but would also get those nuts in. We talked about ways to get more soluble fiber into her day, so switching from a plain bagel to whole grain bread, or perhaps having oatmeal for breakfast on some days with some other soluble fiber rich things added in. Choosing fruit for snacks more often, particularly those that are higher in soluble fiber. And adding in lentils and legumes to her soup or salad. When we talked about the plant proteins, she felt very strongly that was not something she could do, but when I talked about adding them to her soup in small amounts or to her salad, that was a little bit more digestible. She felt like she could probably do that. And then the plan for her is to repeat her lipid panel in 3 months, because it usually takes between 4 and 12 weeks to see a change in lipid parameters. I have not yet seen her in clinic, so I can't report on how things are looking. So now moving into triglycerides, the Canadian guidelines highlighted here really don't have much in the way of recommendations for triglyceride targets, other than the fact that if someone has cardiovascular disease or if they have diabetes and they're at risk for cardiovascular disease, there are some potential therapies that could be recommended for those with a triglyceride level above 1.5 millimoles per liter. But the US guidelines actually they provide a lot more detail around triglycerides. So they've identified moderate hypertriglyceridemia as a level between 175 and 499. and this is fasting or non-fasting. And what they've recommended is to make sure that we're looking at other factors that could be contributing to high triglycerides, because it may not be, there may be other things involved and diet might not be the answer. And I just wanted to highlight, in 2021, there was a updated specific paper looking at managing people with persistent hypertriglyceridemia. There's quite a bit of nutrition focus in this paper, and this figure here was just pulled from there, but it echoes what's in the main 2018 guidelines. Some of the factors that may contribute to high triglycerides are listed here. So certainly relevant to our patients, poorly controlled diabetes is a big one. From a diet perspective, those that are consuming alcohol in excess, diets high in saturated fat, sugar, or high glycemic index foods. When we look at medications, glucocorticosteroids, some of the psychiatry meds that might be used in our population, such as mirtazapine, and then immunosuppressive agents for our post-transplant population. So the guidelines state if you can switch someone to a different medication that does not increase triglycerides, that would be ideal, but I don't know how practical that is for many people. And then dietary guidelines to lower triglycerides really focus on carbohydrates because we know the liver converts excess carbohydrates into triglycerides. So for those that are having really large portions of carbohydrates, talking about smaller portions and maybe replacing some of those more refined grains with whole grains, and really trying to limit added sugars. So sugar, sweets, juice, trying to cut back on those. There's very good evidence that omega-3 fatty acids help lower triglycerides quite significantly. So the US guidelines recommend at least 2 servings of fatty fish per week, reducing alcohol intake for those that drink. For those that are overweight, achieving a healthy body weight can be very effective. And for those that have CFRD, optimizing glycemic control will help improve triglyceride levels. And I just wanted to highlight, this is a resource that I use in practice with some of my CF patients. It was developed at our institution through the lipid clinic, and it is available online to the general population. So the website's listed here, and you can just search triglycerides. We do also have some resources for the portfolio diet and the Mediterranean diet. And then just in the interest of time, I won't talk too much about physical activity, but there are physical activity recommendations in the Canadian and US guidelines because we know there's good evidence that activity will improve HDL cholesterol levels, which is what we want. So this is a topic that as dietitians can potentially come up when we're counseling patients about dyslipidemia. So for the first portion of my talk, I just wanted to summarize some of the key points. So we expect the prevalence of cardiovascular disease to increase with an aging population, and one of the key risk factors is dyslipidemia. Lipids should be screened at least once every 5 years, but this is dependent on risk, and this should be done with a non-fasting lipid profile. And LDL cholesterol is the primary target for cardiovascular disease risk reduction. The portfolio diet, which includes nuts, plant proteins, soluble fiber, and plant sterols, can reduce LDL by 8 to 16%. And we probably should be encouraging all people with CF to follow a heart-healthy diet. And then I'm just going to switch gears for the last chunk of my talk and just talk a little bit about CF-related diabetes complications. So our conventional teaching in the diabetes world is that people with CFRD develop microvascular complications, such as microalbuminuria, retinopathy, and neuropathies. And this is associated with having diabetes for longer and having poor blood sugar control. However, our current guidelines that are not so recent, last published in 2010, they state that because CF patients are at low risk for atherosclerotic cardiovascular disease, it's not clear that lipid elevation requires treatment in this population, and there are no data regarding the efficacy or safety of medical therapy for CF dyslipidemia. So for anyone who works in diabetes, the message has been that people with CFRD don't get macrovascular disease, but we are now realizing that that's not the case. So the current guidelines state that we should be screening using an annual lipid profile only for people with CFRD who are pancreatic sufficient, or if they have risk factors present such as obesity, a family history of cardiovascular disease, or if they're post-transplant. But we know that diabetes is a very significant risk factor for heart disease in the general population, and cardiovascular disease is the primary cause of death in people with type 1 and type 2 diabetes. So what we really should be thinking about, contrary to the current guidelines, is we should consider doing or screening lipids in people with CFRD and intend to treat them similar to other populations with diabetes. So for the general diabetes population, these are considered the statin-indicated conditions. So anyone with diabetes who's over the age of 40, a statin is indicated. And for younger people, if they have had diabetes for a long duration or if they have macrovascular disease, a statin would also be indicated. So these are for the general population, but things that we should probably be thinking about in CF, and hopefully some clinicians are actually applying these to their patients. With respect to screening for microvascular complications, the recommendations that currently exist have really no need for change, but we should be checking blood pressure at every visit because hypertension increases the risk of developing nephropathy. And then we should be screening for microvascular complications every year. And this starts 5 years after the diagnosis of CFRD. So not 5 years after they've been on treatment, but 5 years after the date of diagnosis. And then just lastly, I wanted to highlight some of the CFRD complications that have nutritional implications, and the big one being nephropathy, because the current guidelines state that there is no restriction of sodium and in general no protein restriction in people with CFRD diagnosed with hypertension or microvascular complications. However, in the age of highly effective modulator therapy with people living longer and healthier and better, reduced sweat chlorides, I think we probably do need to consider sodium restrictions in some of these people to help with blood pressure. And certainly for those with kidney disease who are well nourished, I think a protein restriction is probably very appropriate because it will slow the progression of kidney damage. And then with respect to neuropathy, the guidelines that exist for gastroparesis in the general population can apply to people with CF who suffer from this. So smaller, more frequent meals that are low in fiber and low in fat, and that are softer and easier to digest. So in summary, the CFRD clinical care guidelines for macrovascular complication screening are very outdated, and we should consider screening all people with CFRD with annual lipids with an intention to treat similar to other populations with diabetes. Blood pressure should be checked at every visit. An annual microvascular complication screening should begin 5 years after CFRD was diagnosed. So for kidneys, doing an ACR, for retinopathy, an eye exam, and for neuropathy, doing a foot exam. And the nutritional management of nephropathy in particular may differ from the current guidelines because a sodium and protein restriction may be appropriate in some people with CF. So I wanted to thank one of my colleagues who works in the lipid clinic at St. Mike's, Emily Campbell. She was really helpful in sharing her expertise because this is what she does all the time. And Dr. Julie Gilmore, clinic's endocrinologist, for sharing her expertise on CFRD. So I'll now take any questions, and I've put my email address here in case I don't get to your question or if you'd like any of the resources I've mentioned. Thank you.
You have about 10 minutes for questions. And just for those in the back, there's a lot of seats up front, so please feel free to take a seat. You don't need to sit on the floor in the back. And if you want to ask a question, please come to the microphone.
Or put it in.
Or put it in the app. There is one person who has asked if you would post your slides on the listserv.
Yes, I can definitely send them out through the listserv.
I have a question. So you mentioned that, and I may have missed the gist, but you mentioned about not having to fast for the triglyceride levels. Is that for just the triglycerides or for all the lipid panel, and do you have to interpret it differently?
Yes, that's a good question. So for a general lipid panel, which includes triglycerides, it's recommended that people do not need to be fasting, just because the barrier to doing the testing when you are fasting means not as many people are doing it, and they've found that the values don't differ significantly in the fasted versus non-fasted state. However, for triglycerides specifically, there is a mention in the US guidelines saying that a very high fat meal should be avoided. I forget the exact language, but in the 8 hours prior. And we know our people with CF typically consume a very high fat diet. So I think the triglycerides, we need to be a little bit cautious about interpreting because if they have eaten a high fat meal, their triglycerides may be high. And then if they come fasting, they may be okay. So I find the triglyceride piece is a little bit trickier to interpret. If someone has a high triglyceride level, you could always repeat it another day non-fasting to see if it's very different. If they're keen, you could get them to come fasting. But the targets that are mentioned, or sort of the the criteria for what's considered to be high, they've said that is also in the non-fasting state.
That was actually my question.
Fabulous.
Hi. My question is, you mentioned toward the end of the presentation about limiting sodium intake for our diabetic patients. But I was wondering if you were looking at sweat chloride tests to determine who needs to have a reduced sodium intake.
Yeah, that's a really good question. I think what I was referring to is that it's something that we can consider. Certainly, I've encountered people that feel when they eat higher salt meals, they feel, some people feel like a little bit more swollen and just feel less comfortable. But sweat chloride is definitely something to consider, and I think very important for those with a normal sweat chloride or a significantly reduced sweat chloride. For sure, I think they would be more appropriate, whereas for those who are either not on modulator therapy or sweat chlorides haven't changed significantly, I think we have to be very cautious about not encouraging a sodium restriction to prevent them from running into issues with dehydration.
Thank you.
Oh. Sorry.
Sorry, I'm like in the worst spot in the room to come over and use the microphone. But I was just wondering your thoughts on, especially more recent publications on the risk of calcium supplementation and development of atherosclerosis. I'm a little nervous about calcium supplements, especially some of our patients that are using higher doses.
Yeah, that's a really good question. And I haven't done a deep dive into the literature recently, but certainly when I'm counseling patients on calcium intake, for those that aren't getting enough from diet, I encourage food first, knowing that there is a risk of excess calcium intake from supplements depositing on the blood vessels. But for those that feel very strongly that they cannot meet their needs through diet, I feel like supplementation is appropriate because otherwise they're getting very little. But I do usually mention to people that there is an added risk with calcium supplements. So if they can get calcium from diet, that is better.
So two things. One, I tried to put a message in. It wouldn't go unless I was connected to the internet. So if anybody is having issues with that, because there's a couple on here, so I don't know if you guys are not getting them.
Oh.
But my question was, when checking the lipid panel for a CF patient and an intervention is needed, who manages that? Do you refer to the PCP? What do you guys do?
Yeah, that's a really good question. In preparing for this talk, I realized we don't have a good process in place. I think historically for us, the triglycerides get flagged, like our lab flags the triglycerides as abnormal. So sometimes when we see that, we will have a conversation with the patient, especially if it's someone where we think lifestyle interventions, I guess a good example would be someone with diabetes, with poorly controlled diabetes, or someone who's very well nourished or a bit overweight. I would be more likely to have that conversation. Certainly, I think for all of our patients with high triglycerides, we can chat with them because, adding in fish or fish oils is something that anyone can do. But we actually don't have a good process in place. And as I was preparing for this, I realized that the LDL, our lab doesn't flag it as abnormal because it is dependent on the risk. And so a lot of these people probably have LDL levels that are outside of target that aren't being looked at, and not really anyone's aware of it. So after this, I plan on sitting down with our team and figuring out how we manage this. I know our endocrinologist is very comfortable prescribing statins for our people with diabetes. So we do have people on statins who have diabetes, but as far as I know, our respirologists, or you call them pulmonologists, I don't feel that they are overly comfortable prescribing statins. So whether they take on that or whether we are referring more to their primary care providers, up in the air, but definitely something that we need to figure out. It's a good question.
Right, I'm gonna ask a couple of questions that are from the app. We only have a couple more minutes, so for portfolio diet, is it 50 grams of plant protein or 50 grams of tofu and lentils, etc.?
Oh, that's a good question. 50 grams of any plant protein versus 50 grams of soy, lentil, legumes. I would have to look into that. I know when the diet was developed, I think, when I was a student and learned about it in school, because the diet was actually developed in Toronto, soy was the big thing, and it was, tofu, tempeh, these soy meat alternatives, which are also, highly processed and high in salt. But certainly the more recent guidance has moved away from that. But things like pea protein and other plant-based proteins, that's a really good question. I don't know.
When checking a lipid panel and an intervention is needed, who manages that? Do you refer them to the PCP?
I think that question was just,
Sorry,
that's okay. No, I know it's hard. It's hard moderating. We are still figuring that piece out, and I think we need to figure it out as our people with CF get older.
And then I work with pediatric patients with CF for many years. In the history, we told our patients to eat calorie-dense foods in extra portions. Nowadays, with the use of Trikafta, I'm seeing significant weight gain that is more adipose fat than muscle. Knowing dyslipidemia is a possibility in the future, when do you think CF children should be tested for cholesterol?
So the guidelines do state for any pediatric population, screening should begin between the ages of 9 and 11 and repeated every 5 years. They do mention very clearly that cholesterol levels tend to decrease during puberty, so that is not a good time to be checking, and I think that's why they say start between the ages of 9 to 11, because then when you do your repeat screen, they'll be, kind of past that window of puberty. If they are, I mentioned it in the slides but didn't say it, if they are at high risk for cardiovascular disease with family history, screening should begin at the age of 2. And I know there's evidence that the uptake of these of screening at young ages is quite low. So the guidelines state we should be screening at a young age, but I don't know that a lot of providers are actually starting to screen that early.
I know that another question just came in, but we have to move on, so sorry. We can catch Lisa at the end.
Yeah, you can email me or you can come by me. Thank you very much.
What's his name? That's going to come out of the thing. He's in the back. I can see it.
From IT, do we have a pad to do the timer?
iPad, right? Oh, you're supposed to have a speaker time. Okay. See if I can get you another iPad. I can send it to you next time.
I mean, we can do that, so, but it's really.
So, I mean, we can do it, but people after us, people might not be okay with it.
Okay.
I'm just letting you know.
Understood. I will definitely.
Okay, so we're going to move on to our next speaker. So Kelly Stewart is going to come up and speak for us. Kelly Stewart is a clinical dietitian with the University of Utah Adult Cystic Fibrosis Center. She's been working in the field of cystic fibrosis for 6 years. She received her master's at the University of Utah. Her areas of interest include cystic fibrosis-related diabetes, trauma's influence on eating, and helping patients develop interoceptive awareness. And she previously worked as a farmer and professional baker before becoming a clinical dietitian. And she anticipates her next career move to be a kettle corn maker at country fairs. So please come on up.
Good morning. Thank you for the introduction. So I was asked to speak today about aging well with cystic fibrosis, a nutrition perspective, and I would like to actually shift that title. Let's see if this is going to work. To an embodied nutrition perspective. And I have no relationships to disclose other than being an aging human, just like all of us. I'd like to start with a cultural perspective. In our society, aging is not treated kindly, and we don't have to look far to see this. I Googled aging cartoons and getting old cartoons, and here is a sampling of the narrative that our culture has about aging. So the doctor says to the patient, your doctor can only do so much, the rest is up to you, stop getting older. Or the patient says to the doctor, don't prescribe anything for my memory, I like it when I forget I'm old. The frog is sitting on the bench and says, one day you're young, the next day you're sitting at the edge of your bed like this. The woman says to her partner, where did all the years go? And he says, your face. The presumably son is measuring his father's belly distance from the floor instead of his height. And the doctor says to the patient, remember the 20 extra years you added to your life through clean, healthy eating? Well, these are them. Oh. So if we look at the themes of these comics, we can see that culturally we say aging is so bad you need to stop it or at least forget about it, and that it makes us look terrible and feel terrible. And this narrative is especially harsh on women in our society. Now imagine having a chronic disease and very suddenly, unexpected life, unexpected aging. And that's what most of our patients are facing. Aging is hard enough to contend with in our society, let alone also contending with a chronic disease on top of unexpected aging. So then what is aging well? And how do we help our patients approach aging while living with cystic fibrosis? From my perspective, and I'm a clinician, so I'm so glad that we have a community speaker here because this is just my perspective. Aging well might mean opportunities for healing the relationship with the body, for learning embodiment, and for learning attuned self-care. But how do these ideas tie into nutrition? So the first part of this talk, I'm going to orient to our surroundings, specifically our nutrition surroundings. And then the second part, we'll discuss clinical tools that you might use in your clinic. So let's start with where we're coming from. Historically, the approach to general nutrition has been to focus on calories, weight, and education, with the idea that if we appropriately educate our patients on proper nutrition, then they can put it into practice. If only it was that simple. And what has this looked like in cystic fibrosis? It's looked like providing caloric goals, dosing enzymes, educating patients on the importance of their weight in relation to their lung health. And this was an important aspect to cystic fibrosis care. We knew malnutrition impacted lung health, as demonstrated by this classic graph linking BMI with FEV1. More recently, we've had the concern of excess weight gain on modulators, and here's a graph demonstrating significant weight gain on the triple combination modulator in just 24 weeks. Calories, weight, education, they have their place. They are important players in nutrition, but they're not the whole story. There's more on the horizon. And the study of nutrition is quite young compared to other sciences. It's like we've been in a small boat exploring the vast ocean of human nutrition, and on our horizon has been this constant perspective of calories, weight, education. And until recent years, we haven't ventured too far past that horizon. But the problem with weight focus is it's not so controllable, especially when we ask our patients to now lose weight that they gained from modulator use. And many of you heard this example, but one way to think about this is if poodles ruled the world and they told all other dog breeds, guys, you need to look like us. We know that no amount of dieting would change the fact that every dog breed has a different natural weight and shape. And it's a comical and ridiculous idea to imagine, but when we approach that all healthy bodies weigh a certain amount, it's no different, especially when we base it on the flawed BMI tool. We all have different genetics. And even if we all ate the same and moved the same, we would still look different. The other problem with weight focus is that it often causes unintended harm. And research has identified many adverse effects of using weight as a target outcome. And I'll just list a few: distraction from other health determinants, eating disorders, food and body preoccupation, ironically, inadequate nutrient intake, decreased metabolic rate, and increased all-cause mortality risk. And furthermore, weight bias is real in healthcare and negatively affects people's health in terms of care received. Harvard released a study in 2019 which surveyed 4.4 million people, and they measured 6 different biases. Anti-fat bias was the only bias out of 6 to increase over the term of the survey, and it increased dramatically, 40%. And lastly, weight stigma, both internal and external, negatively impacts people's habits. It's associated with increased eating, decreased self-regulation, increased cortisol, avoidance of exercise, and understandably avoidance of healthcare. And so this is one slide that could be a whole talk on its own, and in fact it is. I'm just putting a pitch in here for Saturday morning. We have a whole talk at 7:15 about the harms of weight focus. But the take-home message is that a singular focus on weight not only misses the mark, but creates its own problems. So if we don't want to focus on weight, what do? And that's where we can push further on the horizon, and we can come to see that habits are a crucial aspect to nutrition. And I've advocated for using habits to assess health as strongly supported by research. And this is my favorite study that powerfully drives home the answer that I found over and over in research. This is a graph from a study utilizing NHANES data from 1988 to 1994. And NHANES stands for the National Health and Nutrition Examination Survey. It was designed to assess the health and nutritional status of adults and children in the US. And it's still ongoing. It started in 1960, and it examines a nationally representative sample of about 5,000 people each year. So looking at this graph, the y-axis shows the hazard ratio for all-cause mortality. And the different bars represent the different BMI categories of healthy, overweight, and obese. I'm using quotations as defined by the BMI. And the x-axis represents the amount of healthy habits. So the 4 healthy habits they looked at were fruit and vegetable intake, tobacco use, exercise, and alcohol intake. And as you can see, among those who practice all 4 healthy habits, BMI effectively stops being a factor that predicts mortality. So in other words, habits matter regardless of weight. Okay, so now we're thinking, all right, we've got something new on the horizon. We're going to include habits. And then, shouldn't we be able to help all our patients? We just give them some education, they change some habits, boom, job done. And that's when we realize we just hit an iceberg. And I think of the iceberg as social determinants of health. Because the thing about habits is they're impacted by more than just our willpower. They are highly influenced by our social determinants of health. And here's a truncated list: adverse childhood experiences, stable income, safe living environment, trauma, access to food and medical care, and receiving respectful treatment, education, transportation, pollution, literacy skills, social support, and all forms of discrimination such as weight, race, gender identity, sexual orientation, ability, religion, and so forth. So you'll find a lot of different exact percentage breakdowns across the literature, but I often see around 30% I often see individual behavior impacting health estimated around 30%, and therefore the vast majority of our health is affected by aspects outside of our control, which is not something we normally think about. And given that, this is a quote I always hold in my mind when I'm working with patients. It's from Sonia Renee Taylor, who is a social activist. And she states, "There is no standard of health that is achievable for all bodies." And our belief that there should be anchors the systemic oppression of ableism and reinforces the notion that people with illness and disabilities have defective bodies rather than different bodies. Each of us will have varying degrees of health and wellness throughout our lives, and our arbitrary demands and expectations as it relates to the health and size of people's bodies fuels inequality and injustice. So we're pushing further. Now we're thinking about social determinants of health. We're going to go a little bit further, and I promise this will tie back to aging well. Another aspect we need to consider on the horizon is trauma. And to have cystic fibrosis is to experience trauma. And that trauma extends through all the disciplines: emotions, breathing, moving, and eating. And we can think of trauma in two ways. There's the big T trauma and the little t trauma. So big T trauma would be things like the loss of a parent, or experiencing a natural disaster, or the loss of a limb. And little t trauma would be things like repeated bullying, or chronic emotional abuse, or the chronic stress from a chronic disease. And the key part here is that repeated little t trauma can lead to the same trauma response as big T trauma. And why does that matter? Especially when we consider nutrition. And that's because trauma often takes people out of their bodies. When they experience trauma, a lot of people will go into a flight or fight or freeze response, and they may disassociate from their bodies in order to protect themselves. And the reason that this is so important for us to consider as dietitians is that eating is an inherently somatic or body experience. Imagine you're a patient living with cystic fibrosis and you experience a lot of pain in your body through breathing or through joint pain, or maybe many PICC lines being placed, or from being forced to overeat throughout your childhood in order to survive. All of these quote unquote little t trauma experiences would likely cause you to not want to feel your body, or cause you to feel that your body is unsafe, and therefore you shut off, consciously or unconsciously, feeling your body. So if this happens, how do you know when you're full? How do you know what foods feel good in your body? How do you know if a new habit helps your body thrive? We need to consider the impact of trauma on our patients' ability to nourish themselves. And given the context of trauma, I would say we need to consider the somatic therapy perspective. We live in a society that places very high value on logic, and thus we are socialized to live from the neck up. In other words, we're not trained to feel body sensations and respond to them. Somatic therapy widens the perspective beyond just focusing on logic to include the experience of the body. It is what we would call a body-first approach, working from the ground up instead of the head down. And for the purposes of this talk, there's two main points I want to highlight from somatic therapy. Our body stores our lived experiences, both good and bad. So some of our patients will struggle to feel their bodies after repeated traumas or not want to. And this is something to keep in mind when working with patients who are really struggling to feel hunger fullness cues or other sensations important for eating. And there may be more to the story there, and perhaps a referral to therapy would be warranted. And the other viewpoint from somatic therapy is that the body speaks in sensations. We all know what pain feels like in our bodies, but what about joy? Where do you feel that? Or anxiety? What does hunger feel like? Or exhaustion? I believe dietitians can use mindfulness practices to help people begin to tune into their body sensations. Building a skill set of being able to tune into body sensations can help patients feel hunger fullness cues, what foods help them thrive, or versus not feel so good, and so forth. This is a crucial skill. So if our goal is to help people age well, we want to help our patients explore these broader contexts of nutrition. And as we explore these broader contexts, we can move beyond just managing symptoms to healing the relationship with the body, to patients experiencing embodiment with help from a therapist and dietitian, to patients learning attuned self-care, not just counting calories, following advice, to patients experiencing their body, tuning into sensations, working within their surroundings, and impacting their health in the way they can, while learning how to come into a new relationship with the aspects of their health or body that they may not be able to change as they'd like. So here are some thoughts on putting this into practice, that tools I draw on within my clinical practice. So the first we're going to do all together right now, you don't even have to move. We're going to try a body meditation. And what I would invite you to do is, if you're comfortable, and hopefully everyone joins you in this, is to close your eyes. And first, I'd like you to notice your feet on the floor. What are they touching? What's the sensation like? Is it hot? Is it cold? Is it heavy? Is it light? And the next, I'd like you to notice the energy in your body. Are you feeling lots of energy or low energy? Do you feel energy in any particular location in your body? We're just taking an inventory. There's no need to do anything. And now I'd like you to notice any emotions that you may be feeling right now. And it can be really helpful to view this through the lens of curiosity. There's no good or bad emotion. We're just curious about what emotion might be present. And does that emotion live in any specific area in your body? And then lastly, tuning into your stomach. Where are you on the hunger fullness scale? And how would you describe that sensation? So just taking a moment, taking that inventory, we're just noticing, and you can open your eyes when you're ready. Thanks for entertaining this. This is a meditation I lead every cooking class I teach just before we eat. And the goal is to help guide patients to learn just the practice of tuning into the body sensations with curiosity. And this meditation led to a complete aha moment for one of our 20-something male patients who consistently struggled with overeating and managing his insulin-dependent cystic fibrosis-related diabetes. He told me after the meditation, I realized I've literally never tuned into my body. No wonder I always overeat. And this aha moment took the act of overeating out of that shame frustration spiral and into self-compassionate understanding, which really fostered positive change for him. So as referenced in the body meditation, the hunger fullness scale can be a really helpful tool for our patients, and I'm sure many of you are familiar with this. The thing that I always point out to my patients is that the most important part is viewing this through the lens of curiosity. It's not about never overeating again. It's about noticing, man, I just overate. Isn't that interesting? What set me up for that? What foods did I choose? How did I feel afterwards? Getting really curious about what goes on when you're 1 out of 10 on the scale. How'd you end up there? What foods are you choosing then? So getting curious about the circumstances contributing to where you land on the scale is really crucial. Many of my patients have told me once they realized they overeat sweets when they're 1 out of 10 on the scale, which makes complete sense, who doesn't do that, they worked to tune into their body earlier and eat a balanced snack before reaching empty. The idea of a body story comes from the work of Hilary Canavy and Data Sturdivant in their book, Reclaiming Body Trust, which I highly recommend. And the idea is that every one of us here has a body, and therefore we have a body story. And so often, the story of our body isn't written by us. It's written by others, by our culture, by our doctors, by a diagnosis or numbers like the BMI or a number on the scale. And the invitation is to put the narrative back into your own hands through inquiry and storytelling. And here are some questions they ask. What story was told to you about your body? How did you first learn that your body was a problem? This is a really great question. What do you wish the world knew about your body? What would a story told through a lens of truth, self-respect, and self-love sound like? So you might wonder how this could look in clinic. I use this tool when a patient is really frustrated with a particular aspect of their body or health. So for example, we had a young female patient in our clinic with excellent lung health, but she was experiencing unexplained weight loss, and it really, really upset her. And despite this weight loss, she was still well nourished. Her vitamin levels were within normal limits. Her FEV1 was excellent. She had healthy habits and tested negative for celiac disease. So we felt we had really ruled out any big concerns. When I spoke with her, we explored what the weight loss meant to her and how it fit into her body story. And she shared about as a child, she experienced relentless focus on weight and lung health. And this was actually really comfortable terrain for her. When our team, her new adult team, focused less on weight and more on habits, this scared her. And her narrative about her body was that she had to achieve a certain BMI in order to be healthy. And she asked me, how can I be healthy if I'm not above that specific weight? So the most important part about this was me simply being present to her telling her body story, to her owning her narrative, and to having the space to explore this. I basically listened and offered reflective statements. Sometimes it's not about fixing something, but about providing presence. And one thing I think about is where else in the world do patients have the space to talk about the experience of their body? As the modulators hit the market, one thing we notice is that a lot of our patients lack the actual skill set of healthy cooking. And that's not something that can be taught in a standard clinic visit. You know, like how do you explain, like, okay, you hold a knife, you get the onion. That totally doesn't work. So in response, I created healthy cooking classes that are offered through the University of Utah hospital system that are actually billed to insurance as a shared medical visit. And it took an incredible amount of coordination, almost 2 years, between physicians in the family practice clinic, other dietitians, incredible red tape through administration, and so forth. But now we run a culinary shared medical visit every Tuesday night that always has one spot for a person with cystic fibrosis. And during the appointment, everyone has their own station and we cook a healthy meal together. And the dietitian leads the instruction and the physician leads the discussion on culinary medicine. And the two physicians that teach this are certified in culinary medicine. Part of the magic of the class is that we all cook in a circle and we talk about the successes and challenges of habit changes, and we brainstorm different solutions to different patient problems. And we also always practice the body meditation before we eat our meal. And this appointment, what I love about it is that it does offer education, which is really crucial, but it also offers skill sets of both cooking and tuning into the body. So just a couple weeks ago, one of our patients who has struggled with constipation for many, many years, and we have had repeated discussions about what does it look like to eat healthy, finally attended the culinary shared medical visit. And she learned 3 different healthy meals and went home and shared them with her family. Her husband loved them so much, he had her cook them in huge batches and freeze them so they could always have them available. But what she was so excited to tell me about at her last clinic visit is that she was finally having a daily bowel movement, and she realized that previously she only knew how to eat junk food. And now she knew 2 things, how to eat well and how much better she felt eating well. And another tool is a social media cleanse or fast instead of a food cleanse or fast. So when patients are telling me like, okay, so I'm gonna do the keto diet, we kind of talk about like, what's going on in your social media feed? You know, what are you seeing on there? It can be really helpful for patients to curate their social media accounts. And I really encourage them to cut out accounts that cause body shame or body comparison or morality with food, and to bring in accounts that focus on intuitive eating and health at every size. Or even better, just take a break from social media entirely can really shift the focus from viewing yourself from the outside to experiencing your own body. One of our patients who experienced significant continued weight gain from the triple combination modulator, despite excellent habits, found this tool incredibly helpful. She changed all her social media feeds that caused her to feel any body shame. And in this way, she actually shifted the algorithm of her social media so it kept promoting what she wanted to see. And she told me this really helped her focus on just caring for her body instead of judging and shaming her body. Another tool I use is the mindful eating exercise. And this is to help patients cultivate savoring food and having internal guidance on food choices. This is one thing that I'll explain right now and you'll think like, yeah, whatever. But I really encourage you to try it. And it really only works if you do this in person and you're eating the food and the patient is eating the food. Doesn't have to be anything fancy. I'll grab like saltine crackers. And you just go through all 5 senses. So we start with sight, color, texture. What does it look like? We smell it. We place the food in our mouths. And the important part here is if you have a fork to put it down so that you can just really focus on what's the initial sensation of the food, how does the texture and flavor change as I chew it. And then lastly, which I think is really important, is noticing how does the food land in my body after I swallow it. Years ago, I did this with a patient who was inpatient at the time, and she was eating a ton of potato chips. And so we got a bag of her favorite potato chips, and we ate the chips together. And I remember she opened her eyes and looked at me and said, "These have a terrible aftertaste." And I never even noticed it. And so suddenly she realized it's not about I should eat less potato chips. It's, oh my gosh, I don't even like potato chips. And I would be amiss if I didn't highlight the power of curiosity and self-compassion. When we can start to view habits through curiosity and self-compassion, we can see the wisdom of coping habits and then imagine different ones. And curiosity and self-compassion help us move from the blame-shame cycle into attuned self-care. When I hear patients say, I know I shouldn't, but that's my cue for getting curious. And working from the framework that coping skills are rooted in wisdom, I ask patients to really explore their quote-unquote bad habit. So to give you an example, I was talking with a middle-aged male patient with impaired glucose tolerance. And he sheepishly told me that every day, at the end of the day, he gets in his car, drives to the gas station, and gets a large regular soda. He was so shameful about this. But we really decided to focus on what prompts him to do this. He's tired, he worked all day, he just cared for the family all evening. This is his downtime. And when we viewed it through that lens, we decided this makes so much sense. And then we got curious. What else could he do instead? Could he go for a walk around the block? Would he enjoy that? What if he drove to the gas station, paid for a soda, but just filled it with plain bubbly water? Would that give him the same satisfaction? And our goal was for him to run a series of experiments and see, is something else just as satisfying? And this is an example that education only goes so far. Most of our patients know better, but curiosity and self-compassion can take us further. And I like to think about every person as a whole galaxy of complexity and lived experience. When our patients are really struggling with a habit change, I ask about their family narrative around bodies and food growing up. We have a patient in her 40s who's an insulin-dependent person with diabetes who eats junk food every day. And she's been educated, and she knows better. And yet, she can't stop. And she was really frustrated. One day I asked her about her earliest memories of junk food. And she told me something so powerful. She said, my mom was a single mom, and the way she expressed love was through letting us eat whatever junk food we wanted. That's so powerful. And we explored the idea of when you're reaching for junk food, are you hungry or are you really craving connection to your mother or craving comfort? So food is so much more than simply fuel, and seeing the broader context that food has is crucial. And the last tool I'd like to mention is using somatic movements to help patients down-regulate their nervous system. I am not a certified somatic therapist, but I've been spending a lot of time learning about it as much as possible, and I just want to share the tip of the iceberg. So many of you are likely familiar with the vagus nerve. It's the longest cranial nerve in the body, and it plays an important role in various bodily functions. The one that we really are interested in is digestion, and it also is involved in the regulation of emotional and psychological responses. The cool thing is we can really help regulate the vagus nerve through really simple movements. So I'm sure a lot of you have seen this, the butterfly tap, where you alternatively tap your hands while folded across your chest. There's another one where you can stand like this. On each side, up and down. And you can also do it through tons of different things like humming, singing, yoga, any type of movement. Walking is often a bilateral stimulation that helps calm the vagus nerve. So I believe this is relevant to dietitians because the state of the vagus nerve not only affects digestion, but also the ability of somebody to tune into their body sensations. I find that when patients are really anxious, it's hard for them to notice a body sensation of hunger or fullness. When patients tell me they're really stressed in their daily life, for example, they can't feel hunger cues. I had a patient tell me this a couple weeks ago. I asked her to just perform some type of somatic movement around mealtime to see if that would help her down-regulate her vagus nerve so that she could better tune into her body. And this is another thing where it's like you can understand this intellectually, but I really encourage you to try it. It's pretty fascinating. I also know some people might worry that this is outside of our scope of practice as dietitians, but it's absolutely not. It was designed to be used by any discipline, and we're just simply working with the body instead of just the head. So when we fail to honor the expansive nature of nutrition, and such as only focusing on caloric intake or weight on the scale, it's kind of like we're telling our fellow sailors, don't go there. The world is flat and you're going to sail off into the abyss. But just like the early explorers, our perspective has been skewed. The world is round and vast, and I believe as dietitians, we have a duty to explore this vast, round world further. So what is aging well? I believe one of the potentials for aging well is embodiment. is shifting from doing things to the body and on the body to doing things with the body and for the body, and shifting to view the body itself as a resource. We will all age, and I hope that we use that opportunity to choose how we approach aging. And may it include viewing the body as a resource instead of something to overcome. And may it include developing a relationship with our body that we want to be in for a lifetime. Thank you.
So we do have some questions from the app. Do you have any suggestions for patients who have an intense fear of developing CFRD to help calm the fear and help them incorporate enjoyable foods within their normal diet?
Yeah, sure. Anytime a patient is really fearful about a condition, I ask them, let's get really curious. Let's explore this fear together. Is it fearful of insulin? Is it fearful of the diagnosis? What does the diagnosis mean to you? Just kind of imagine yourself as an explorer and ask the patient, let's just check it out, see what's out there. Because usually there's some really strong internal narrative that we can reframe, and then it becomes less fearful, and that helps open patients up to new experiences.
And out of curiosity, what are some of the recipes that are shared in the culinary medicine classes, and how did you get funding to implement these courses?
Okay, so that's a great question. Well, how it happened was I started working in community centers teaching this, like test running it, just on my own time. And then once I had some solid recipes down, I pitched it to the administration, who said, sure, but we're not going to give you funding. And I am so lucky I work with 5 or 6 people who said, we don't care, we're going to do this anyway. And so we worked unpaid for 2 years. And my clinic manager told me, you can roll it into your general hours, don't worry about it. And then once we figured out the model of a shared medical visit, that's when we realized we could bill insurance for it. So we did a ton of work going to other clinics that had that shared medical visit and figuring out the exact billing codes. I mean, this was a real work in progress for a while. And so once we figured that out, it's self-sustaining, because our goal was for it to be financially independent, that could be expanded across the University of Utah healthcare system, which we're in the process of doing. And the recipes, I got to tell you, we trialed some, and some were just complete flops. And so we have gone through many iterations. I'm happy to email them to you if you'd like. The first class, we do a chopped salad, which sounds pretty lame, but it's really just to get the skill sets of chopping vegetables, and we make our own salad dressing. And that people love that recipe. We use chickpeas for protein and quinoa as a whole grain that also has some protein. The second class, we do a tofu stir fry, which is everyone's favorite. And usually that's the first introduction that people have had to tofu where it actually tastes good. And there's some tricks to that. And I always start the class with asking people who are my tofu haters, and then we check back in at the end of the class. And then the third recipe we just relaunched because we were struggling over and over, but now we do lentil tacos, and we have people cook lentils that we've soaked, and they grate in carrots and other veggies, and they make an avocado crema. It sounds so fancy, but it's quite easy. And then we all eat dinner together. Hopefully that answers your question.
Mitch Ramsey, I'm an adult gastroenterologist from Columbus, Ohio. First off, thank you so much for the very compelling and riveting talk. I think you've described this pattern of healthy eating and healthy digestion that's really advanced my thinking on a lot of aspects that we deal with in the clinic.
Thanks.
I'm going to ask you very specifically about one symptom
Sure.
that I've really struggled in our clinic, and that's bloating.
Yeah.
Because I think it addresses aspects that you've talked about today. It's not just diet, it's body image. Some people say, after I eat, I feel big. And that's the main presenting symptom.
Yeah.
Other times it's belching, other times it's constipation. It's really challenging. Can you talk a little bit about, through this lens that you've described, how you approach bloating symptom?
Totally. I hear you. It's probably the biggest thing I struggle with as well. So we look at it from a bunch of different ways. We'll address, like, what are you eating? When does it happen? I'll ask people to keep a food log. And I don't know about all of you, but I have literally never found the FODMAP diet helpful for bloating in cystic fibrosis. Not once. Outside of CF, it's great, not in CF. So I think there's some bloating that seems to inherently come with CF. We'll also explore like Miralax use, things like that. The other thing I talk with people a lot about is their relationship with the bloating. Because what so often happens is that they experience bloating and they immediately go to, I hate this, I hate my body, I hate my stomach, I look fat, yada, 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 yada. And sometimes I ask them, can you just put your hands on your stomach, and we do this together in clinic, and just compassionately approach your bloating. Oh, hey, stomach, I'm so sorry you're in pain again. Ah, it's uncomfortable. I'm right here with you. It sounds ridiculous, right? But it's actually really helpful, because I think what goes on is that people experience bloating and then they're hating on it the whole time, and they get in these thought and shame spirals. Then we think about, what does bloating mean in this country? Oh, people are gonna think I'm pregnant, I'm not pregnant, or I'm fat. And then we might explore, what does being fat mean? So we can like look at all those ways. And then the other thing that I can say is just paramount, get a new outfit. I tell people, seriously, you wanna go on your worst day. I want you to go to like a used clothing store, so you don't have any idea about like sizes, and don't get all that junk in your head. Go to used clothing store, go when you're really bloated and you feel absolutely disgusting, and find an outfit that you're like doing a little bit of dance to in the mirror, and that's your safe outfit. Because I think what happens is that people experience bloating and they panic, and then they think, oh my gosh, I don't know what to wear, and a lot of women's clothes are really restrictive, like the skirt, yeah, I totally brought a dress to change into. Like, there's no way I'm gonna wear this all day. So I asked them, like, get a safe outfit so that when you have that experience of bloating, you don't also have your waistband digging into you, reminding you every 30 seconds that you're bloated. So those are the things that we talk about.
That's great, thank you.
Yeah.
Yeah, thank you so much. I loved your message. So I love the weight neutral and body neutral approach. Do you have any thoughts on BMI criteria for transplant?
Oh yeah, that's an interesting question. Are you thinking like from a weight gain or weight loss perspective? Both.
But referrals
Yeah.
for like, hey, patient's BMI is too high.
Yeah.
Had some of those come through. Just I don't know, some thoughts on that. I know it's tough.
Yeah, that's a tough one. I've talked with my colleague Amber, who's here, about those guidelines that are related to surgeries that are life-saving, whether it's a transplant or let's say somebody's going through a gender-affirming surgery, but they're blocked by a BMI. I think that is one of the few times when I will tell patients, look, we may not agree with this, but this is a life-saving surgery. So we're gonna do everything we can do to get the surgery for you. And I worked with one patient who just couldn't get her BMI up, and we did everything. And it was like, we viewed food as medicine in that way, of like, she had to do nocturnal tube feeds, she had to eat throughout the day, she was overriding her fullness cues. I think that the difference is that we were talking about all of it. I wasn't just saying to her, do it and deal with it. We explored how uncomfortable it was, but also how important it was. And then we had the plan that once she received the transplant, she could go back to different type of eating. So that's a complex one, but I right now I think about it as, let's get him to the surgery and then let's plan for a different approach after the surgery.
My question is about trauma and screening for trauma in the clinic. That's something that I have seen a lot and try to be sensitive to, but my problem that I run into is, how do I actually identify it, because I'm not a mental health professional, and then what does the follow-up look like for our patients?
Yeah.
And then just real quick on the bloating, there is a talk tomorrow at 3:30 from Dr. Durleith about highly effective modulars and bloating specifically. It's a 2-hour talk, so
yeah, I'm planning to go to that one. That's a good question about trauma. I guess I work from the lens that I assume all our patients have had some degree of trauma. Because I think having just repeated hospitalizations, repeated medical treatment throughout your life, you're gonna have some level of trauma. And I don't have a clinical way of diagnosing it because that's not my field. It's more that when I see patients getting really worked up about something, I get curious, like, I wonder if there's some trauma here. And I don't say to them like, hey, are you traumatized? Like, is this a really big trauma aspect for you? It's more like, that's my cue to slow down and see if I can help bring some calmness in. I might ask them, like, can we do a few movements together? It might feel a little silly, and just kind of see how they respond. The other thing I'll say is our team social worker is so knowledgeable of all our patients that she often will tell me they have trauma around X. And so then we'll kind of create a plan together. That's the beauty of interdisciplinary care, right? I do think dietitians, we need more training in trauma.
Hi, I have sort of like a logistics question.
Yeah.
Like this work you're doing is like big and wonderful, but how do you have time in your 10 to 15 minute clinic visit to make that happen? Are you seeing patients like outside of clinic or?
Yeah, that's a great question. So I'm probably spoiled in that we are not limited for time in our clinic. So our team will have a preclinical meeting where we talk about every patient, and we'll prioritize disciplines often at that meeting and say, all right, they're not going to get anywhere without X, so you go in and you stay back. So there's a lot of flexibility there. Because our clinic only bills for physician time, we use every discipline as whatever time they need, they take. So sometimes it's a 5-minute intervention and sometimes it's an hour. That would be more of like a new CFRD diagnosis. And we do see patients outside of clinic hours if they need some help with follow-up. Like I've had several patients go off to college and we'll do Zoom calls and talk about how do we approach healthy eating on campus, things like that. But I think our clinic is unique in that we're spoiled. And unless we've been in there for 45 minutes, nobody is really giving us a hard time.
Hi, my question actually isn't for the patients. How do we change the providers and the other support staff to get into this?
Totally, yeah.
Because they're used to, after my provider's been doing it for 15, 20 years, get your BMI up, gain weight. And now the Trikafta, others are saying they're so fat.
Right.
They need to lose weight, which they may not be saying that, but then we're coming in behind it trying to get this, to get them on board on it. It's great that if we want to do it, and the social worker is all about it, having gone through various issues yourself, that we can emphasize with it. But when you've got the support staff saying other.
Yeah, totally.
How do you deal with that?
Yeah, that's a good question. I actually just want to mention one quick thing on the previous question. All the tools I did today, you could do in under 5 minutes. That's why I highlighted them. So like sometimes those tools we'll just do over and over. Or maybe I'll just say, hey, I want you to explore this question about a body story and kind of send them off if they're in a time crunch. So I think it is possible, by the way, to have 10 to 15 minutes. In terms of how to work with the rest of your team, I just view it through the same lens of curiosity and self-compassion, because we're all in this culture together. So of course they've been inundated with a weight-centric model. That's what they went to school through. That's what us dietitians endured through school, right? So of course it's gonna take a long time. And sometimes I get frustrated and I go outside and I'm like, ugh. But most of the time I try to just get really curious when someone's stuck, when they keep bringing up their weight. I'll say, okay, I hear that you're really bringing up their weight. I really want to shift and look at their habits, because remember, weight isn't so controllable, and I'll just try to give gentle reminders. And sometimes we just agree to disagree. There's one physician on my team, we have different opinions about it, and we're candid, and we also tell patients we have different opinions. So she'll say to a patient, Kelly's going to tell you your weight doesn't matter, you should lose weight. And then I'll go in, and I'll say, did she tell you to lose weight? Yeah. How you feeling? Let's talk about that. So I think we call our team like a wonderful dysfunctional family, because we all have different opinions and we just get really candid about it. But I think the problem is if we as dietitians approach our team as like, oh my gosh, get on the bandwagon, they're not going to get on the bandwagon, because we know shame and blame never work. But if we can say to them, like, that's so fascinating that you are on another diet, why don't you tell me how you're feeling? That might like foster a little bit of a shift over time.
I'm sorry, we have to move on to our next speaker. But if you put it, there's a lot of questions still in the app, and we'll try and get Kelly to answer all of them. I'm sorry. So if you put your question in the app, we'll pass it on.
Okay. Thank you. Should I just say?
So I'm Becca Summer. I'm one of the co-moderators with Kim. I'm from the Indianapolis Adult Center, and I am super excited. Laura has agreed to talk today. Laura is 38 years old. She's from Indianapolis. She lives with her husband and her 10-year-old daughter. She's also a licensed psychotherapist in private practice. I've had the pleasure of working with Laura for about 7.5 years now. Did you get me over to the adult side? But Laura is very modest. She has also been a patient-family partner for our clinic, so we have used her insight as a patient many times. I know as a dietitian, I've always appreciated Laura's clinic visits and just insights from the patient perspective. I'll sometimes talk about my thoughts on CF nutrition, and I just always have appreciated her insights and willing to talk through those things. So thank you, Laura.
Here, good morning. You will hear a lot of overlap in what I'm going to say with what Kelly said. I think we're going to be best friends, by the way. You had me at Sonia Renee Taylor. So I'm very happy to be here, and hopefully some of what I'm going to talk about provides some like real life context for some of the ideas presented earlier. So as Becca mentioned, thank you for the intro. I am 38 years old. You always have to start with age when you're a CF patient and you're introducing yourself. And I've been asked to share this morning about my experience with nutrition and journey towards intuitive eating. So I'm gonna give you a little bit of background first. I was born in 1985 in Indianapolis and diagnosed with CF. Get my tech here. There we go. At 2.5 years old. So as you all know, a diagnosis of CF at that time was devastating. The gene would not be identified for 2 more years, and there were no available treatments and very little hope for families. So not knowing what else to do, my family, participated in the first Great Strides Walk for the Cystic Fibrosis Foundation and started raising money for research. Over the years, more and more people got involved, including my extended family and our community as a whole, and it became my mom's mission to raise money for a cure for CF. She, in fact, kind of did that thing, wildly enough, right? But didn't know at the time that the triple modulator drugs would ever come, as she was hustling for each $20 donation. She held on tight, we all did, and our Great Strides team, the Jaywalkers, obviously, have raised over $1 million in small individual donations. So my mom's here today, actually, so you can give her a high five on her way out. You can also give her props for this like pale pink 3-piece suit that she dressed me in. So I started speaking at fundraising events, Great Strides mostly, when I was 5 years old, with the title Ambassador of Courage. I was aware I had CF growing up, but didn't lead a life that was drastically different from my friends. I played sports and went to sleepovers, got good grades, happened to have a chronic progressive illness in addition to those things. I was hospitalized for the first time at 11 years old and began to realize that the split that I'd created between my CF life and my regular life might not be as easy to keep separate as I thought. More on that in a minute. Not long after my first hospitalization, speaking of little t trauma, I started middle school. I was on very high doses of prednisone, as well as IV antibiotics at the time to treat a nasty aspergillus reaction. With that long-term prednisone, I had severe moon face, especially compared with my tiny, tiny body at the time, and even grew small amounts of hair on my shoulders. During this important developmental time, and one that's pretty awful for everybody, my PIC line and my face shape were both an outward sign of being other that I was really scared of and did my best to reject. I continued in relatively good health throughout adolescence and my teenage years. I was on IV antibiotics from home about once a year, but kept all the plates spinning by excelling in tennis, having a fun social life, and graduating high school in the top 10 of my class academically. The split, or dichotomy, I mentioned earlier, was required for me. to maintain each of these pieces. I was the good CF patient. I never had a period of time in which I rebelled or was non-compliant with treatment. And everybody at my care center seemed to like and approve of me, which I loved. And I spoke eloquently most of the time and with confidence at events while asking people to donate money to help save my life. I performed normal very well. I would go on dates with boys while actively infusing IV antibiotics, and they never knew. I would take my enzymes in secret as well, so no one would expect anything was out of the ordinary. I worked really hard to have an undefeated regular season on my high school tennis team and won both MVP and mental attitude awards. I was a master of separation and disconnection, and it worked really well until it didn't. Up until this time, my relationship with food was singularly focused. Before diagnosis and before I could remember, my mom said I cried all the time, had painful bowel movements, and seemed to be starving. I would eat constantly. She said one of my first words was lima bean, and I'd eat anything in front of me, including frozen peas and things so hot I would burn my mouth because I couldn't stand to wait. For as long as I can remember, the philosophy was to consume as many calories as possible. I was taught the healthiest lunch for me on clinic day was a Big Mac, fries, and milkshake at the McDonald's located in the hospital. My mom cooked, thankfully, and cooked very well, and worked really hard to provide high quality, high calorie food. Excuse me. Despite that, I was underweight most of my childhood and constantly had people commenting on my body size and how skinny I was and asking why. Living within a relatively small Indiana community, a lot of people knew I had CF because of our fundraising efforts, but that did not stop a lot of uninvited comments about my body. My high school tennis coach said that my freshman and sophomore year at each match, the coach of the opposing team would approach her and ask if she was sure I was healthy enough to play because of my size. By the time my junior year rolled around, which is the picture in the blue, I'd gained enough weight to pass as healthy. Within the context of healthcare, my weight was a constant topic of conversation and an intense area of focus and stress. I'd be weighed at each appointment and would talk about the number on the scale with both the dietitian and my physician and be reminded that weight correlated with lung function and that poor lung function is very dangerous. We'd talk about exactly what I was eating and look for places to work in more calories. I loved my care team growing up and now, and they were very confident and very caring, but we were all working to get me through. Excuse me. We were all working to help me survive and get through, and so the anxiety inherent in that was inescapable. After graduating from high school, I went to a small college about an hour from home. I lived in the dorms, thanks to the vest that was developed just in time for me to be able to do that, and played on the tennis team there as well. I ate in the dining hall with everyone and continued to hide my enzymes and my CF from all but a few friends and the tennis team. The luxury of a community in which I wasn't as well known made this easier, though the loud airway clearance in my dorm room was a little bit tricky to keep under wraps. I always have had a fair amount of GI issues from pancreatic insufficiency, but my pain and malabsorption levels were at their highest when I was in college. Part of that was due to not taking my enzymes at appropriate times. For example, if I took them before the dining hall and my friends and I took a detour on the way, I would take them too early. At that time, the risk of abdominal pain felt lower than the risk of vulnerability and asking my friends for accommodation. I was able to maintain the disconnect from my body my first year of college, but knew it was likely unsustainable. That separation became impossible my sophomore year of college. I had an exacerbation the summer before requiring IV antibiotics and continued to work and engage socially as if nothing were different. Not surprisingly, after 2 weeks of 2-a-day tennis practices in 100-degree heat to prepare for the season, I had another exacerbation soon after the first, requiring another 3 weeks of strong IV antibiotics, including gentamicin. During the treatment, I woke up at college one day realizing that something felt very different and very wrong. I got out of bed and tried to walk to the bathroom, but couldn't stay upright without holding onto the wall. So I called my parents to come and get me, and my dad had to carry me down the stairs because I couldn't balance well enough to walk them on my own. That separation that I had been so proud of, and I had white-knuckled my way through to ensure all versions of myself were presentable and sparkly and without flaw, was about to come crashing down. I spent several days at home, barely functioning, not knowing what was wrong. It was finally determined that the gentamicin that I had destroyed all my vestibular nerves. So in the short term, I could no longer drive, couldn't walk around campus by myself, especially at night, and worst of all, at that time, was told I would not play competitive tennis again. I was full of rage at this point. I had done everything right. I had been a star CF patient, totally compliant, and this was how I was rewarded. Lots of questions were flying through my head. If I wasn't an athlete, could I still convince myself that I was normal and healthy? If I couldn't prove that was true by playing high-level tennis, was it still true? If I couldn't maintain the disconnection from my body to allow myself to pretend my discomfort and fatigue wasn't as strong as it actually was, would I have to look directly at it? Excuse me. I started vestibular physical therapy to regain as much functioning as possible and went back to school because if I took a semester off, I would have lost my health insurance. I kept functioning externally. I maintained friendships and got good grades, but internally, excuse me, I was terrified. The rage I felt turned into depression, and my fury turned towards myself, and specifically my body. I started to absolutely hate the appearance of my body and started heavily restricting food and compulsively exercising. I was caught in the cycle of restricting, binging, purging, and body checking. I don't know exactly why my need for control over my health manifested in food and body issues. It could have been the focus on my weight and food for so long within my experience of healthcare. It's likely that the damaging cultural narrative around women's bodies was just too pervasive and strong to escape. I also wonder about those first 2.5 years where I was starving and never able to get what I needed in terms of nutrition and satisfaction. Regardless of the cause, through my experience of disordered eating, I found one of the loves of my life, psychotherapy, and got medication that helped stabilize my mood. I found more of myself in the last 2 years of college through therapy, and the disconnect between myself and my body started to shrink. I was no longer engaging in dangerous food behaviors, but did not yet understand what allyship with one's body looked like. I returned to the tennis team my junior year of college, miserable and having lost so much skill and ability with a bilateral vestibular loss, but determined to prove that I could outsmart and outstubborn my body and would make it function as I wanted it to. After college, I started in a graduate program for clinical psychology and began to discover what authenticity felt like, thus closing the gap of separation within myself a little bit more. In the next few years, I started my career as a psychotherapist and met my husband, Dave, while maintaining good health and continuing in the consume as many calories as possible mindset. In 2013, I gave birth to my daughter, Ruby. I know, that face, that little face. It was really, really hard to decide if we should have a baby, as I had never done anything to potentially risk my health in the past. But after talking about it with my care team and looking at the research, we decided we wanted to try. So after 36 hours of labor, Ruby was born on her due date, healthy and perfect. Her giant cheeks and webbed toes stole our hearts immediately. Despite research indicating the health of CF women that give birth generally went back to baseline postpartum, mine did not. My health significantly declined during pregnancy, and I was hospitalized for the first time in 14 years due to a lung infection. At my sickest, my FEV1 was in the 40s, the lowest it had been by well over 20%, and we were really scared. As expected, I had gestational diabetes, which gave way to CFRD. Postpartum, I had several years of low lung function and increased exacerbations, and I eventually had to quit my job as a therapist to focus on caring for myself and Ruby full time. I also lost my dad to glioblastoma in this period, and the future looked really grim. In the time I wasn't working, though, Orkambi was approved, which did not improve, but certainly helped stabilize, helped stabilize my health. It was a welcomed and much needed reprieve and felt like real, true hope. It was in those Orkambi years that my relationship with my body shifted a little bit. Pretending I didn't have CF was no longer an option, and I also had a new role as mom. My fatigue had never been higher and energy lower. I'm not sure exactly what did it. Excuse me. I'm not sure exactly what did it. Probably watching my incredible daughter fully embodied, but I allowed a bit of self-compassion to finally creep in. I think my relationship with my husband and how fully he saw and honored me also helped me access self-compassion. He would, of course, never blame me or consider me weak for having a physical need and allowing myself to meet it, and I was able to absorb some of the respect he had for me and turn it towards myself. I was lucky he stuck around, considering we dated for 3 full months before I told him that tiny detail about having a chronic, debilitating illness. At that time, I promised myself and him that I wouldn't sugarcoat anything, and I'd be honest about what this meant for my life and what it would look like for our lives. And I think this was the first time I was truly honest with myself about what I was facing. And looking directly at it, I saw more of myself and started reconsidering the idea that my body was my enemy. What if instead it was actually my ally? What if it held really important information for me to have, like when I needed to rest or to move or to eat? And what if I listened to and trusted that information rather than trying to override or control it? During this time, I took more naps than ever and discovered my deep love and unquenchable thirst for pickleball. The summer before Ruby started kindergarten, I hit the jackpot and got a spot in the Vertex trial for the triple modulator drugs. I knew right away something was different. The evening of my first dose, Ruby and I were reading Harry Potter on the couch, and I started feeling really congested in my lungs and coughing a lot. I soon found out that my FEV1 had increased almost 20%. Since my first dose of Trikafta 5 years ago, I haven't needed an antibiotic, either intravenous or oral, to treat an exacerbation. My energy changed completely, as did my understanding of my body and food. I didn't realize until I took Trikafta that before I had it, my body was starving. I was hungry all the time, never satisfied, and couldn't get enough to sustain me. I now had the ability to think about more than calories in eating and to attune to my body in a way that I never could before. I learned that the separation that I had held between myself and my body was adaptive, and that if I really listened to the cues my body was giving, the cues my body was giving me, I would have rarely gotten out of bed. I was absolutely exhausted all the time and had no business playing collegiate tennis or running cross country. I unconsciously assumed ignoring my body held more opportunity and freedom for my life. Since I've seen my body as an ally, I've realized the opposite is true. I eat what I want, when I want, and in listening to my body's cues, to determine those things, I happen to consume the most nutrient-rich food I ever have. For breakfast each morning, I have a green smoothie. I don't do that because I should, or because it's healthy, or because I see my body as bad and deserving of punishment via spinach. I do this because when I start my day with a green smoothie, my arthritis pain is less and I have more energy, and they taste pretty good. I eat what I do now because I care for myself and want the best quality of life. Most days, that's a green smoothie. Some days, that's gummy bears, because I am a CF patient and it is written into my DNA to love gummy bears, and they're delicious. 2 years ago, I opened my psychotherapy private practice. I specialize in women's health with concentrations in trauma, anxiety, and disordered eating. There has been so much parallel process in doing trauma work professionally and looking at my own disembodiment. So many of us separate from our bodies as we find it is unsafe to stay in them for one reason or another. We can see disembodiment or dissociation on a spectrum. Some with severe capital T trauma histories are completely dissociated and lack memories from the time of the trauma, or feel as if they are outside their bodies watching themselves function in a movie or a video game. We're all somewhere on that spectrum. Most of us in our day-to-day lives have adjusted to living disembodied or to seeing our true selves as separate from our bodies. For example, in our culture, the language we use about our bodies is that we have one, like we have a car or a cell phone. We see our bodies through a lens of possession rather than a place of being. This disconnect is not innate. We are born embodied, but learn to distance ourselves usually as a means of self-protection. For me, I disconnected from the terror of having a chronic fatal illness. Also, in our culture's hierarchy of bodies and their worthiness, a disabled body is not desirable. Once I realized the level of separation I was holding from my body and how long my body had been screaming for my attention, I started to intentionally pursue embodiment. I did this through psychotherapy, specifically with a somatic technique called brain spotting that I also practice, and also in the little details, day to day. I now notice when I have an ache in my shoulder or a sore muscle in my hip. I know when I need to take a deep breath and close my eyes. I know when I need to rest and when I need to move. I know when I'm experiencing physical sensations in my body that represent emotion. And I'm able to listen with curiosity rather than judgment at what information those feelings are bringing to me and how they inform me of my needs. I know when I'm hungry and when I'm full. The intentional practice of embodiment has led directly to an intuitive eating practice that has both greatly benefited my physical health and contributed to more joy and satisfaction in eating and a greater quality of life overall. Dr. Hiller McBride has been the person that's taught me the most about embodiment. You can find her work and research in various platforms, but my favorite is her book called The Wisdom of Your Body. There she says, being a body, seeing the self is inextricable from our physicality, and our physicality as the expression of our personhood invites us into wholeness. But when the self has been shattered and fragmented, as it has for so many of us, collecting the fragments, believing they belong to us, and naming them as good is a politically rebellious, spiritually powerful, and biomedically healing process. My personal work of embodiment, my personal work of integration and the process of intuitive eating have gone hand in hand, and that both involve self-trust. I'd controlled my body so long that I never realized that the opposite of control, trust, was missing. Instead of forcing my body to fit my expectations, I can now trust my body to let me know what I need and what's best for me. There's a mountain of evidence that our bodies hold wisdom, and being disconnected from our bodies has consequences. Look at the long-term health results of childhood trauma. Studies have linked a greater number of adverse childhood events with greater risk of heart disease, cancer, bone fractures, chronic lung or liver disease, diabetes, and stroke. I don't think we can talk about health, nutrition, or intuitive eating without acknowledging that a certain level of embodiment is required and that emotional trauma is stored in our bodies. I would love to talk all day about trauma. I promise you I will not. But if you're looking for more resources, both of these books could be helpful. So the $1,000,000 question, right? What does this look like in your work as dietitians? And so, again, some of this has been said, so I'll go quickly. But like the rest of healthcare, it's important to be trauma informed. When I was growing up, mental health was not something discussed often within the CF community because everybody was trying to survive. Now that there's more room to address more than the lungs, it's essential to have systems in place, check in with CF patients about their emotional experiences in their body and how that's contributing to their health. I know there has been movement towards implementing assessments like the PHQ-9 for depression, but I wonder about also screening for trauma by offering an ACE or adverse childhood event assessment. Excuse me. I have paper because I am a millennial that stick together. So I do wonder about an ACE assessment. And in the area of nutrition specifically, I wonder how patients can be supported in building a practice of embodiment. Intuitive eating practices can absolutely help with that, but without a baseline ability to hear your body's cues, it's really difficult to get started. With the big T traumas, as measured on an ACE assessment, it would be clear to refer to a mental health professional. I also wonder about those little T traumas we've all experienced that contribute to disembodiment, especially with NCF or other chronic illness, and how that can be identified. I wonder how collaboration with a mental health professional could contribute to greater understanding and practice of embodiment that would lead to better nutrition and better health outcomes. Lastly, as mentioned before, I wonder about less focus on weight. While it's one measure of a body's functioning and health, there are many others that are important and more well-rounded and potentially have less consequences for the patient. I would consider this especially for those that identify as female, as the cultural narrative around women's bodies is especially dangerous. In listening to and trusting my body and practicing gentle nutrition, my health has never been better. I eat food that tastes good, feels good in my body, and also move and rest intuitively. I'm able to fully access the joy and laughter that Ruby and Dave bring to my life, and the deeply meaningful work of walking alongside women through their trauma recovery. Thank you for having me today and for holding space with gentleness and respect and humor and patience. It was an honor to speak with you.